to do, which is really sort of the second part of this. We're going to discuss specifically TPN cholestasis. And the reason that TPN liver disease, essentially. The reason I chose this is because I figured that while you may or may not see acute liver failure, you're certainly going to see this problem in the nursery. And so I think it was probably worthwhile changing it up a little bit. So we're going to talk about managing intestinal failure, subtitled A Guide to Nurturing the Bowel and Saving the Liver. So our learning objectives today would be to learn the definition of factors leading to and the prognosis for intestinal failure, understand the segmental functional characteristics of the small and large bowel, know the principles of intestinal failure medical management, including the importance of an intact colon in continuity, recognize, manage, and prevent TPN liver disease, which we'll talk about more on Wednesday, and become familiar with the newer medical and surgical therapies, including transplantation for intestinal failure. So how do we define intestinal failure? We used to call it short bowel syndrome. We don't call that anymore. We call it intestinal failure because it doesn't necessarily indicate a short bowel, just a bowel that's not functioning. So intestinal failure is defined by a critical reduction in functional gut mass below the minimal amount necessary for adequate digestion and absorption, which is required to satisfy nutrient and fluid requirements for growth. Those who have intestinal failure, by definition, are depending on parenteral nutrition. And let's look at some contrasts. The adult, you would have less than 200 centimeters of bowel, which could lead to a state of intestinal failure. And the etiologies are generally secondary to Crohn's disease, vascular problems, tumors, radiation, or unusually patients who have celiac disease refractory to therapy. In infants and children, obviously, a smaller length of bowel, so anything less than 75 centimeters can lead to intestinal failure. The etiologies, however, are significantly different. Congenital malformations, in our patient population, necrotizing enterocolitis would likely be the most common cause. Extensive aganglionosis, which we hardly ever see, a volvulus, a pseudoobstruction, and then something like microvillus inclusion disease or tufting enteropathy that we discussed earlier this year. So what are the really important questions one has to ask when determining whether or not a patient has intestinal failure? What is the length of the remaining small bowel? Is the colon intact and in continuity? Is there an ileocecal valve? And when you see a patient in the NICU who they're asking you to see for, quote, short bowel syndrome, these are the questions you should be asking. What part of the small bowel is gone? And I apologize, I have a bad cold and I'm trying to see if my voice will hold up. So I apologize in advance. What part of the small bowel is gone? Is the remaining bowel healthy? Is the remaining child healthy? First and foremost, when one is discussing anyone who's had a resection, is there an ileocecal valve? Because the presence of the ileocecal valve is crucial for determining the length of the remaining bowel as it pertains to normal or abnormal functioning. If you have less than 40 centimeters and no ileocecal valve, 40% of patients historically were dependent on parenteral nutrition in some amount after 8 years. If there's less than 20 centimeters plus an intact ileocecal valve, that gives you a fairly good prognosis to be parenteral nutrition independent after 4 years. And we're talking here specifically of pediatric patients, who are asked to see in the NICU. What part of the colon, what part of the small bowel is resected? Well, the jejunum is a high capacity, low concentration system. The junctions between cells tend to be leaky, allowing for paracellular uptake. The fluid in the jejunum is isotonic, and there is no electrolyte transport against the concentration gradient. The ileum and colon are significantly different in terms of their functioning. These are low capacity, high concentration systems. The junctions between cells are tight, very little paracellular transport. The fluid in these structures tend to be hypertonic. And here, electrolytes will be transported against their concentration gradient. So the net uptake will be far greater than the amount secreted, and that will be against the concentration gradient. The other importance of the ileocecal valve and the ileum close to it is that nutrients entering the ileum induce secretion of peptide YY. This results in inhibiting gastric and intestinal motility, pancreatic and gastric secretions, all mediated by peptide YY. So peptide YY slows intestinal transit and limits pancreatic and gastric secretions. The other thing you have to know is that these areas of the small bowel are markedly different in their absorptive capacities. Most macro and micronutrients are absorbed predominantly in the proximal jejunum. These include fat, sugars, peptides and amino acids, heavy metals, calcium, water, and electrolytes. These major macronutrients continue to be absorbed in the middle intestine. By the time you get to the ileum, while some absorption of nutrients also takes place, in the distal small bowel, that portion is uniquely responsible for the uptake of bile salts, vitamin B12, and zinc. These three elements, bile acids, vitamin B12, and zinc, are absorbed solely in the ileum. Water and electrolyte absorption also takes place variably throughout the small and large bowel. Of the 8 to 9 liters of secretions, both endogenous and exogenous, that we take in, 7,000 mLs are absorbed by the time you get to the end of the ileum. In the cecum, we have 15 mLs left, 1,500 mLs left. Again, this is in the adult. 14 of 1,500 mLs are absorbed in the colon, so that the normal adult excretes only about 100 milliliters of fluid per day. So here we have 7,000 of 9,000 mLs absorbed in the jejunum and ileum, and 1,400 of 1,500 mLs in the colon. So the colon is a very highly efficient absorber of fluids and electrolytes, while most are absorbed in the small bowel, but the greatest efficiency is in the colon. The resection is going to predict where problems are going to be. If you have the loss of jejunum, there is more compromise of nutrient absorption initially, but eventually the ileum will compensate for jejunal loss. However, if one resects the ileum, this is not compensated for by the jejunum. The more distal the loss of intestine, the more severe the accompanying effects, and the more severe and extensive will be long-term morbidity. So what are the factors affecting the outcome of intestinal failure? Certainly, the presence of growth factors, the presence of an ileocecal junction, the length of the remaining bowel, the presence of underlying intestinal disease, where the disease has been resected, the contribution of other digestive organs, the appropriateness of nutritional support, but perhaps overriding all of these is patient age. The small intestine is about 600 to 800 centimeters in length in the adult. In the neonate, the small intestine length is about 250 centimeters. It's 120 centimeters in length during the second trimester and doubles in length during the third trimester. It doubles again in the first 18 months of life. So premature and younger full-term neonates have a greater capacity for intestinal growth and bowel adaptation. It is this factor, this ability to double the length of the intestine in the first 18 months of life, which offers the best prognosis for children, for newborns who've had intestinal resection. So first and foremost, how do we combat excessive fluid losses? Remember, the colon is the most efficient fluid absorber. Therefore, the first thing we always ask the surgeons when we go to the NICU and find out that a patient has an ileostomy and a colostomy is hook up the colon. Because if you can have fluid entering the colon and the colon is normal and functioning, you have a highly efficient water absorber. Of course, we can use oral rehydration solutions. Loperamide has been used to try to slow intestinal transit, and octreotide, which is used not only for GI bleeding, but also to reduce gastrointestinal secretions. Octreotide is a long-acting somatostatin analog. It is an anti-secretory agent which delays gastric emptying. It can be given subcutaneously or continuously IV. However, it is associated with complications, cholelithiasis, and perhaps most importantly, it inhibits growth hormone as well as inhibiting bowel adaptation. So it can be used short-term in the most severe cases. But again, if the colon is not intact and in continuity, placing it in continuity is the best thing that can be done to limit fluid losses. How do we provoke bowel adaptation? Well, diet is one way we can do it. Whenever possible, the most complex nutrient substrate will be the best. So that long-chain triglycerides are better than medium-chain. Peptides are better than amino acids. Complex carbohydrates are better than simple sugars. Perhaps most importantly, because complex carbohydrates have a much less of an osmolar impact on what goes on in the bowel. Oral feedings are better than intragastric feedings, which are better than intraduodenal feedings. Enteral is better than parenteral feedings. Studies have shown that if you place an experimental animal on parenteral feedings exclusively, within several days, the bowel mucosa will atrophy by as much as 50%. So the absence of enteral feedings is, by definition, going to be associated with reduced bowel adaptation. Trophic feedings, even feedings given in very small amounts, is better than no feeding at all. And finally, polymeric formulas are better than elemental formulas, obviously depending upon tolerance. The advantages of fat cannot be overstated. Fat induces bowel adaptation. Fat slows gastric emptying. Fat slows intestinal transit. And obviously, fat gives you more energy for the same grams of nutrient than does carbohydrate. And whenever impossible, of course, long chain is better than medium chain. However, the use of long chain triglycerides will certainly depend on the length, function, and anatomical location of the residual bowel. Take all the help you can get. In a newborn who's had an intestinal resection, the best nutrition is still mother's milk. Take advantage of lingual lipase and salivary amylase, which are high in concentration in the newborn. Epidermal growth factor is present in the saliva. Gastric lipase is present. And also non-nutritive sucking is going to help not only in enteral nutrition absorption, but also in normalizing intestinal motility. Now, I put this slide up because it was published in JPGN in 2021 and gives you a general idea of how we can try to wean patients off of TPN. Again, this will vary significantly from patient to patient, depending on all the factors that I've already discussed. Whenever possible, when starting feedings, use own mother's milk. Should you use an extensively hydrolyzed feed plus MCTs? Well, again, that's going to depend largely upon what bowel is present, what's the location, and what's the length. If the ileum is intact, there may be no need for medium-chain triglycerides. However, with extensive ileal resection, since MCT do not require bile salts for absorption, they will be the preferential lipid nutrient. So you want to start feedings as soon as stool is passed, or 24 to 48 hours after surgery. And you want to begin with bolus or continuous feedings. And again, this is totally dependent upon your evaluation of the individual patient.
I have a question. If own mother's milk isn't available, did this study look at donor breast milk, or did they look at that and not recommend it?
Again, donor breast milk, the problem with donor breast milk is how it's handled, because if it's pasteurized, it destroys a lot of the factors that are going to be present in own mother's milk. So you're probably not going to use donor milk because of that reason, because it's going to have reduced growth factors compared to a native mother's milk.
Thank you.
You want, if a patient, all of these patients are going to have ostomies, you're going to want to maintain the ostomy output at less than 30 milliliters per kilogram per day. And also, there should be normal residuals in the stomach and a normal frequency of stooling. And again, that is going to vary from patient to patient. You want to try to increase the levels of fluid taken enterally by 10 to 20 milliliters per kilogram per day whenever possible. And then, again, by 4 to 6 months of age, you want to start complementary feedings, trying to avoid high osmolality elements such as sugars. You want to start, therefore, with starches, which are more complex, have much less of an osmolar load, and with protein and vegetable sources of nutrition. And whenever you start any food, you want to start that pure food and wait 2 to 5 days between foods that are being introduced because of, again, the possibility of food allergy. At all times, you need to monitor weight, height, stool quantity, the presence of diarrhea. Be monitoring for vitamins, electrolytes, trace minerals. We discussed in our board questions D-lactic acidosis. That's really related to bacterial overgrowth, and we'll discuss that. And we'll also say something about plasma citrulline, which can be very helpful. Keep in mind that any patient who's long-term on parenteral nutrition may develop a food aversion, and this has to be managed in close collaboration with our nutritional consults. Whenever possible, again, I talked about use the colon for fluid absorption, but keep in mind that the colon does more than just absorb fluid. It is a major repository of carbohydrate salvage, producing short-chain fatty acids that are absorbed. Fermentable fibers in the diet, such as pectin, guar gum, and methylcellulose, can be broken down in the colon by bacteria, and short-chain fatty acids salvaged. Of course, again, the best case scenario is the intact colon in continuity. With the loss of the colon and the presence of an ostomy, you have significant losses of fluids and electrolytes, and the amount lost can be dramatic, and it's shown here for sodium, potassium, trace minerals, iron, zinc, and copper. The colon, as I mentioned, is a digestive organ. 90% of the organic acids produced as a result of bacterial fermentation of complex carbohydrates are absorbed by the colonic mucosa. And this carbohydrate can be used not only by colonocytes, but also can be absorbed into the circulation for energy requirements. The role of the colon as a digestive organ is shown more graphically in this slide. The intracolonic digestive process can generate up to 1,000 kilocalories per day. Here, the blue line are subjects with no colon remaining, the red line with 100% of the colon remaining, and the green line is somewhere in between. As you can see, the difference between no colon remaining and zero and all the colon intact is a significant value in terms of fecal energy loss. And so up to 1,000 kilocalories can be salvaged per day in an intact colon. Hypergastrinemia is also going to be a problem. However, it's not a bad problem because gastrin is a potent trophic hormone for intestinal growth and will occur after any massive resection. This not only leads to an enhancement of intestinal growth, but also leads to increased acid and gastric volume with acidification of the duodenum and jejunum. So patients who have had a massive resection, one should consider placing them on some acid-limiting agent, such as an H2 receptor antagonist or a PPI. The downside, of course, is a bacterial overgrowth because our gastric acid is our main barrier against bacterial invasion. Slowing the transit is extremely important. Of course, with ileal resection, we lose peptide YY, which is the ileal brake, and so we have reduced small bowel transit time, which means less ability of the remaining bowel to absorb nutrients. So what we try to do is delay gastric emptying any way we can. Loperamide, it can be used, but also a diet. Remember, fat is a potent retarder of gastric volume, as is fiber. So the use of fat and soluble fiber are important nutritional elements, not only because of nutrient concentration and because of colonic salvage, but also to delay gastric emptying, which can partially compensate for loss of the ileal brake. Bile acid malabsorption, of course, is going to be a tremendous problem in patients who've had the ileal resected. Patients missing the terminal ileum, but with enough small bowel for adequate fat absorption, can be managed nutritionally. Remember that active transport of bile acids occurs in the terminal ileum. These bile acids, if they are not absorbed, can cause tremendous colonic secretion and diarrhea. The liver also tries to compensate for enteric loss of bile acids by increasing bile acid synthesis. So the way to manage that, of course, we talked about medium chain triglycerides. They don't require bile acids for absorption, but cholestyramine has been used successfully. We usually use about 200 milligrams per kilogram per day. There are problems. It does bind fat-soluble vitamins and can cause a hyperchloremic metabolic acidosis. So it has to be closely monitored. But from a pharmacologic standpoint, cholestyramine may be required in order to reduce bile acid loss. Fiber is another absorber of bile acids that may help in this clinical scenario. Bacterial overgrowth is a significant problem.
I'm sorry, just to emphasize the point, Dr. Schwarz, that the last slide points out that the bile salts absorb the vitamins, so one needs to be particularly looking into the fact that the Questran is given at a different time from when the kids get the fat-soluble vitamins, if it is enteral, not parenteral.
Right. And of course, we can give water-soluble analogs well, if you give water-soluble analogs of the fat-soluble vitamins, that can help avoid the problem as well.
Does giving a bunch of vitamins at the same time, like competitively inhibit it from absorbing bile acids too, or is it just that it prevents the vitamins?
No. I mean, the amount that you're going to give is trivial in terms of volume, so it's not a problem.
Okay.
Bacterial overgrowth is a significant problem. The risk factors are tight anastomosis, no ileocecal valve, that's the barrier between the ileum and the colon, hypoperistalsis, and again, acid blockade. And not only causing clinical symptoms, bacterial overgrowth can lead to bacterial translocation. Remember, if it gets up in the jejunum has a leaky tight junction, and that will be a significant problem. D-lactic acidosis. I gave you a board question a couple of weeks ago about the child coming in looking like a drunken sailor who's had intestinal surgery. That's a tip-off for D-lactic acidosis, which you should all be familiar with. And also, obviously, if you have bacterial translocation, that can lead to liver injury. Treatment can involve luminal antibiotics, when necessary, surgical procedures. We'll talk about that later on. And probiotics is something that is of interest. I probably would not give it to someone with bacterial overgrowth, but post-treatment, there may be a role for probiotics in trying to establish a non-pathogenic, if you will, intestinal flora. So, how do we avoid complications? And here we're really talking about iatrogenic complications. Keep in mind that we want to limit protein intake to less than 3 grams per kilogram per day. And this is particularly going to be the case if any patient has intestinal failure related liver disease, where the ability to handle a protein load may be limited. Oxalate stones. Can anyone tell me how oxalate stones are formed?
You mean from the precipitation of calcium oxalate?
Yeah, well, calcium oxalate, can calcium oxalate be absorbed?
No, you can absorb oxalate and you can absorb calcium, but calcium oxalate has very low solubility. Right.
So normally we get calcium oxalate, we excrete it, but the problem is when you have fat malabsorption, you use up the calcium, you get oxalic acid, which can be absorbed, and that can form stones. All right. Feeding aversion, use of trophic feeds and non-nutritive sucking may help. Fatty liver, avoid excess calories. Carnitine is something that's I think it's sort of a no harm, no foul agent that can be added. It can certainly help in terms of mitochondrial transport of lipids. Most patients are not carnitine deficient, but carnitine is often added to the regimen. And the use of enteral feedings or ursodeoxycholic acid may be helpful in preventing the development of cholelithiasis. These are the foods that are high in oxalate. Remember, calcium oxalate in the gut is fine. Calcium oxalate in the kidney is not. So these are the foods that one is going to avoid in patients with short bowel syndrome, particularly if they have ileal resection. And and there's a wide variety of them, and you should keep these in mind. Perhaps the most important thing we can do, and we're going to talk about this again a little bit more on Wednesday, is to avoid line infection. When Dr. Rabinowitz and I were working together at Long Island College Hospital, we were able to reduce the incidence of line infections by almost 100%. How was that possible? Well, just by assuring that there was one nurse on every shift who was trained to handle the line. Meticulous education and site care given by a qualified individual with limited number of individuals having access to the line is the most important thing that anyone can do in terms of trying to limit line infections. There should really be only one nurse on every shift who's managing the lines. And when the more people you have invading the line, the greater the risk of infection. And we try not to invade the line for blood drawing. Antibiotics should not be given through the line unless one is treating line sepsis. And give all medications through a peripheral line if at all possible. Flushing the line and the use of heparin may help. Vancomycin for any breaks in the line expectantly to prevent infection. And if we want to use TPA for suspected clots, obviously, that is something that can be used successfully. So, one of the arguments...
Again, may I interrupt for one moment?
Sure.
The other thing that is being used quite a bit, I don't know if you're going to get to this, is the ethanol locks.
I will not get to the ethanol lock today, but that's been used certainly in someone who's had an episode of line sepsis. The use of an ethanol lock can be very successful in preventing further incidents. Okay, so whether we should save or not save the line. Fungal infections in general, you're going to have to take out the line. Staph aureus used to be an indicator for taking out the line, not so much anymore, but one has to be very careful about the management of Staph aureus and assure that the patient is responding to appropriate therapy. Infection by enteral organisms such as gram-negatives and enterococcus, again, it's going to be dependent upon how the patient responds to antibiotic therapy. And the so-called hang in there is when you have skin staph, non-aureus type staph. These can often be managed successfully without having to pull the line. Again, everything here that I'm talking about, no way, toss of the coin, hang in there, pull the line, this is going to change from patient to patient, and one has to be aware of the risks of these infections, not necessarily that it absolutely indicates that you're going to be able to follow these rules. The exception being a fungal infection. In general, none of these are going to be managed successfully without removing the line. So when should you pull the line? If there are persistent positive cultures after antibiotics, persistent fever on antibiotics, even with negative cultures, the patient is hemodynamically unstable, evidence of DIC or embolic phenomena, and of course, any peripheral involvement, such as thrombophlebitis or endocarditis. This is just a guide for you to be aware of, and you have to, again, manage each patient individually. This is a problem we're going to talk about more on Wednesday. Someone want to tell me what they see in this slide? First of all, what is it? Organ, please.
Liver.
Liver. What do you see?
I see some bile ducts with stuff in them. I
So
see hepatocytes.
do you see, yeah, this is a bile duct. Maybe, I don't think it's a bile duct. This is actually not a bile duct. What is this?
Oh,
What happens when you get cholestasis? We talked about it. You get rosetting of hepatocytes. It's as if the hepatocytes are trying to form a bile duct.
huh.
This is not a bile duct. This is a rosetting of hepatocytes, and here you have bile, and here you have more bile. This is more rosetting, and here you have intrahepatic cholestasis. All right, so you've got cholestasis. What else have you got?
It looks like there was maybe a lot of fat in the hepatocytes
Yeah,
because I see a lot of clear areas now.
Okay, so from now on, I don't want Dr. Schroeder to answer any questions. Okay, all right. Anybody else?
Sorry.
All right. So
a hint. Where do you see the brown?
Right. So what's this?
Could you make the arrow bigger so they could see it easier?
I don't know if I can make the arrow bigger. This is cholestasis and steatosis. This is intestinal failure associated liver disease. All right.
So what's the brown then, given that information, fellows? That's not Bryce.
I am not sure.
What do you think it is? What's it look like?
It's bile?
Yeah.
Bile.
Where is it? Look, what's the structure around all those brown spots?
Bile ducts?
Yeah, it was an excellent guess, and the quizzical nature of your voice made it clear that it was, but still, that's correct. It's inside the bile ducts. You can see the structure of the circle around there. And I could also ask Steve, when was this slide made?
So this is I'm not sure. This may be. I think this may just be rosetting, Tom. I don't, because this isn't. I don't really see. I have to explain. Here's the portal area over here. I think this is the start of a portal area. So I think this could be easily called a bile duct, but I believe this is really rosetting.
I was thinking it was a bile duct that was injured.
Yeah. Well, so you've got intrahepatic. Certainly, you've got intrahepatic cholestasis, and probably also extrahepatic cholestasis. So,
yeah, I was just looking at the circular nature of the the cytoplasm, basically. Right. Like with rosetting, you get that, but it's infiltrating cells to some extent, so it's not the same.
Right.
But this is this looks like it's structural and hepatocytic to me, but that's fine.
So the nature of intestinal failure associated liver disease, in the newborn, it tends to be cholestatic. In the adult, it tends to be steatotic. Here we have both. So what are the risk factors for intestinal failure associated liver disease? Prematurity, because of the immature intrahepatic circulation and the accumulation of toxic secondary bile acids. The longer you're exposed to parenteral nutrition, the greater the risk. All right? And what letter is missing from PN? That's a joke. T. Because patients with peripheral parenteral nutrition don't develop intestinal failure associated liver disease. Only those on central or total parenteral nutrition. Lack of enteral feedings because of small bowel bacterial overgrowth and a dilated bowel. Infection, sepsis, endotoxemia. All right. Intestinal failure. All right. Surgical procedures. And again, the parenteral nutrition component. What's the lipid? Soybean lipids, as we'll see later, contain high omega-6 polyunsaturated fatty acid precursors of pro-inflammatory eicosanoids and increased amounts of plant sterols, all of which can exacerbate intestinal failure associated liver disease. So it's a balance between liver injury and liver protection. Immature liver, high risk. Early sepsis, NEC, high risk. Impaired bile acid recirculation with ileal resection. Nothing in the bowel. Bowel rest. Bowel rest is good for virtually no one, except for very short periods of time. Continuous parenteral nutrition-related intestinal stasis. And again, phytosterols, which are present as part of soybean oil emulsions. And we balance the risks of liver injury with what's available to protect the liver. Early oral or enteral feedings. A balanced of appropriate nutrients. A balance of amino acids. How are we adjusting our amino acid supply to allow for not only normal nutrition, but bile acid conjugation and the use of bile acids that may avoid a liver metabolism. There are certain classifications of amino acids which don't require liver metabolism. I'm thinking, of course, of the branched chains. Cycling parenteral nutrition. I remember every year I used to send down to the NICU the recipe for cycling parenteral nutrition. Having an appropriate fatty acid supply, again, limiting omega-6 fatty acids, and again, sufficient vitamin E required not only for growth, but also for metabolism and as a potent antioxidant. The causes of intestinal failure associated liver disease, again, TPN related, is shown in green. I'll have more to say about this on Wednesday. Disruption of the enterohepatic circulation, intestinal stasis with bacterial overgrowth and translocation, prematurity, and now we come to the TPN related causes, recurrent catheter related sepsis, inadequate macronutrient intake, right, or the wrong balance of nutrients, the excessive intake of long chain polyunsaturated fatty acids with subsequent lipoperoxidation and phytosterols, all related to soybean emulsions, and the overload of heavy metals, not only aluminum, iron, and chromium, but also copper. These can result in toxicity to the liver. What we do know is that patients with NEC tend to do better with intestinal failure in terms of parenteral nutrition dependency than do non-NEC intestinal failure. And the reason is quite simple and is shown here. This is the proportion of patients on parenteral nutrition and the age in years. These are the NEC patients, and these are the non-NEC patients. Can anyone posit a reason why the NEC patients do better? It's really quite simple. All right, Bryce, you can answer if nobody else is going to answer.
I actually don't know either, so.
Well, it's common sense. When you resect bowel in a patient with necrotizing enterocolitis, what's the status of the remaining bowel?
I mean, it's often somewhat injured, but...
It's usually normal.
Oh.
These are not patients with, you resect the dead bowel, but the remaining bowel you hope is functioning normally. In patients with non-NEC intestinal failure, these are patients who tend to have megacystis, megaureter, microvillus inclusion disease, tufting enteropathy, other disorders where the bowel that is intact, it does not function normally. So how do we manage intestinal failure associated liver disease? Engage in a diagnostic workup. One of the first things that I ask the surgeon is how much bowel is remaining. Unfortunately, we used to have this motto, never trust a surgeon with a ruler. but you're probably going to want to image the bowel to see exactly how much is available. And then you need to determine whether the problem is nutrient or non-nutrient related. Again, the nutrient-related causes excessive lipid, excessive glucose, what kind of lipid is given, is the patient receiving enteral nutrients, what's the status of the enteroparacirculation of bile acids, and is there a problem with nutrient excess? The non-nutrient are, of course, sepsis, cholelithiasis, very short bowel, the presence of bacterial overgrowth. Are there infectious or other metabolic causes? Are medications causing the problem? So you have to really try to tease out what is causing the problem of intestinal failure, liver disease. In some cases, investigate and eliminate that cause. In other, certainly those that are nutrient related, it's not difficult to try to optimize the nutritional intake to limit the risk of developing liver disease. What are the best practices to prevent cholestasis? Cycle the TPN, which reduces hyperinsulinism and steatosis. Feed the gut, again, can't emphasize that too much. Avoid excessive calories. And remember that you should not only be looking at the total number of calories that are being consumed, but what's the non-nitrogen to nitrogen or the protein to energy ratio. The non-nitrogen in kilocalories to nitrogen in gram ratio should be 150 to 200 to 1. This is not grams of protein, it's grams of nitrogen. And how do we convert grams of protein to grams of nitrogen? Divide by 6.25, all right? So the non-nitrogen kilocalories to nitrogen in grams should be 150 to 200 to 1. Anything that is above that is going to give you excess carbohydrate or excess calories. Those calories are going to be used to synthesize fat and are going to exacerbate steatosis. Avoid excess lipid. Remember, the maximum is 3 to 4 grams per 120 kilocalories per day. And I'll have a little more to say about that in a moment. Avoid oxidant stress. Again, monitor your heavy metals, which are your main source of oxidative stress. Provide antioxidants. Make sure that things such as selenium and vitamin E are present and are available in your solutions. Ursodeoxycholic acid, again, in the cholestatic patient may be of use. Cycle your antibiotics. These, of course, will be for patients who've had bacterial overgrowth or who are at risk for bacterial overgrowth. The ones we typically use are metronidazole, gentamicin, and rifaximin. And again, most TPN solutions now are taurine supplemented. Remember, taurine is your preferential conjugate for bile acids in the liver in the newborn. So here it is. This is a slide of the document I always used to give the NICU people every year. This is how to cycle TPN. It's probably still down in the NICU. And this takes your targeted energy intake and gives you a general guide to how to cycle TPN. The goal is to try to keep patients at least 6 to 8 hours per day off of parenteral nutrition. We now know, of course, that lipid plays an essential role in the development of intestinal failure-related liver disease. Lipid peroxidation injures canalicular membranes and inhibits bile acid transport. So we want to control the amount of lipid and the rate of delivery. And certainly, patients who develop hyperbilirubinemia or thrombocytopenia that's an indication, if not for stopping lipid, to significantly reducing it. The commercially available parenteral nutrition lipid emulsions is shown here. The classic is intralipid, of course, which is 100% soybean oil. Then we have SMOF lipid, which is a combination of soy, coconut, olive oil, and fish oil. And then we have omegavin, which is 100% fish oil. The earlier studies have shown us that when we substitute fish oil, that's the black figure, versus soybean oil, the blue line, we look at direct bilirubin. This is up to 27 weeks from baseline. You see that the direct bilirubin level, obviously a marker of cholestasis, is virtually zero in patients who are managed on omega-3 fatty acids compared to those who are managed with soybean oil that have a very high bilirubin level. But what if you don't have access to omega-3 fatty acids? Well, there's a simple, at least temporizing maneuver, and that is to limit lipid intake. This is a study done by our friend John Thompson at Montefiore, published in JPGN, looking at growth and essential fatty acid status in children with intestinal failure. And what this group did was they limited TPN in 9 patients with intestinal failure, and they limited the fat emulsion dose to less than 1 gram per kilogram per day, as shown in this column. All of these patients demonstrated an improvement in weight and height Z-scores, and virtually all of them did not develop triene tetraene ratios that were suggestive of essential fatty acid deficiency. So you could both limit essential fatty acid deficiency and achieve growth and weight gain even by limiting lipid intake to less than 1 gram per kilogram per day. What about surgical management? Well, with the development of intestinal rehabilitation techniques and increasing knowledge of how to prevent intestinal failure-associated liver disease, the use of this surgical management of short bowel syndrome has decreased dramatically over the last 5 to 10 years. The role of surgical management, when considered, is to conserve the bowel. It is to attempt to lengthen the bowel surgically, and finally, intestinal transplantation. Again, this is a modality which is being used less and less frequently as our ability to rehabilitate patients with intestinal failure has improved. The non-transplant surgical options include something called the longitudinal intestinal lengthening and tailoring procedure, and it should be used only in patients who have intestinal diameters greater than 3 centimeters. Remember, what happens to the bowel after intestinal resection over time is that the bowel starts to dilate, and you need sufficient amount of bowel that's present in order to engage in a lengthening procedure. So you should have an intestinal diameter greater than 3 centimeters. The residual of small bowel should be longer than 40 centimeters, and the length of the dilated bowel should be greater than 20 centimeters. If that's the case, then if you deal with an intestinal lengthening and tailoring procedure, 50% of your patients will respond favorably. The other procedure, which is probably used now more frequently, is the so-called STEP procedure, or serial transverse enteroplasty. This is the LILT procedure. It's useful with segmental dilatation and non-functioning intestine due to dysmotility and bacterial overgrowth. You see what's done here. You have the bowel that's sort of split in two and put together in this way, so it sort of lengthens the bowel. Of course, the bowel has to be dilated because each segment of bowel is going to be half the diameter that you started out with. The step procedure is shown here. Here you have the initial small bowel loop. A stapler is used to make and close incisions in a V-shaped alternating pattern like this. I think you can see it better here. Here you see the V-shape, and then there'll be one up here and one down here. And gradually you see what happens. The bowel is effectively doubled in length. Hopefully it ultimately gets to this configuration. Of course, we want to conserve the bowel whenever possible. Either medically or surgically limit as much bowel loss as possible. This is particularly true in the patients with NEC undergoing surgical resection. Remember that preservation of even some of the colon is highly beneficial because of its ability to absorb fluid, electrolyte, and to engage in carbohydrate salvage. Finally, the prompt establishment of bowel continuity through stomal closure and reanastomosis is associated with more rapid weaning from parenteral nutrition. Well, there have been changes in the paradigm over the last several years. The number one was glutamine supplemented TPN, glutamine being the precursor of citrulline. I'll talk about that. Short-chain fatty acid supplemented TPN has been tried, but more recently, the use of smofflipid or omegavin can save the liver. And finally, what may now be the holy grail of bowel conservation is the use of GLP-2 to grow the gut. GLP-2 is made in the L cells or enteroendocrine cells. We've seen these previously of the small intestine and colon in response to luminal nutrients. And this is a chromograninase stain of these enteroendocrine cells. I've shown you that previously. What does GLP-2 do? It increases barrier function of the gut epithelium. It stimulates crypt cell proliferation, inhibits enterocyte death or apoptosis, slows gastric emptying, and increases splanchnic blood flow. All the things we want to achieve in managing the patient with intestinal failure. In animal models of intestinal transplantation, GLP-2 compared to placebo decreased breath hydrogen after a sucrose load, otherwise making it that it increased the absorption of sucrose, obviously, increased small bowel weight for length, increased mucosal weight for length, and increased DNA in bowel segments. In human trials, the initial ones were done in adults without a TI or colon who had no postprandial secretion of GLP-2. They were given 400 micrograms BID for 35 days, resulting in increased weight, increased lean body and bone mass, and reduced fat mass. In this randomized placebo-controlled trial of teduglutide or GLP-2, this was studied to see whether it could reduce parenteral nutrition or IV fluid requirements in patients with short bowel. It was the first long-term randomized placebo-controlled trial of teduglutide, and the drug given in a dose of 0.05 milligrams per kilogram per day significantly reduced TPN requirements. And this is this was published in JPGN, and here we have a double-blind randomization to either 0.025 or 0.05 milligrams per kilogram per day, given subcutaneously versus standard of care. And then there was follow-up at 4 weeks. And if we look at patients' primary endpoint, which was a 20% reduction in parenteral nutrition requirement, these were the patients given standard of care. Only 11% reduced their parenteral nutrition requirement by 11%. Those given the 0.025 milligrams per kilogram dose reduced this 20 achieved a 20% reduction in parenteral nutrition requirement by 54%, and that was bumped up to 69% when the dose of teduglutide was increased. What about intestinal transplantation? Can we predict the need for it? Well, if you have less than 20 centimeters beyond the ligament of Treis and no ileocecal valve, that patient is unlikely to respond to medical or surgical management. Patients who have gone over 4 years with no weaning of parenteral nutrition, patients with persistent hyperbilirubinemia, patients with a low level of plasma citrulline. And again, what's the disease etiology? And as I alluded to in an earlier slide, those patients who have a priori a non-functional bowel are those that are likely to need intestinal transplantation. Those with total aganglionosis, pseudoobstruction, megacystis, microureter, microcolon syndrome, MVI, and tufting enteropathy. The number one predictor, of course, is your bilirubin level. Patients who are on long-term TPN had a reduction in bilirubin of 0.9 milligrams per deciliter per month. Eventually, these patients would be expected to be able to be weaned from parenteral nutrition. Those who are requiring either small bowel or liver transplantation, their bilirubin increased. And those that died on the waiting list, their bilirubin levels increased even more. So a reduction in total bilirubin is going to be your best indicator of long-term survival, certainly of the liver. I mentioned about citrulline. Glutamine is converted to citrulline in the enterocyte. In patients who have a citrulline level greater than 19 micromoles per liter, 87% of them could be weaned from parenteral nutrition. Of course, since citrulline is made in the enterocyte, the more enterocytes you have, the more citrulline you can produce. Those whose citrulline level was less than 19 micromoles per liter, 100% remain parenteral nutrition dependent, and it correlates with the development of intestinal tolerance and the length of the small bowel remnant. And here, yeah.
Go ahead.
All right, so here we have a citrulline level. I wonder why we don't monitor this even more unless we're doing it now. Here's a citrulline level as a function of bowel length. Here's the citrulline level. Here's small bowel length, and here's that magic number of 19. The higher the citrulline level, the longer the bowel. If the citrulline level is less than 19, these patients tend to have less than 100 centimeters of remaining small bowel. Those who have a higher citrulline level have a much longer length of remaining small bowel. So, what are the potential candidates?
I'm sorry, Dr. Schwarz. Just in answer to your question, did the fellows know how to get a citrulline level?
I'm assuming it's a serum level.
Yes. How do you get it? You know the answer to the question. It's a little tricky. You request a serum amino acid level, and it automatically will come with it.
Right.
And we should be monitoring it. So
we do when I make a consult.
So who are the potential candidates for intestinal rehab? Infants with no liver disease who have more than 15 centimeters of small bowel, children with greater than 40 centimeters of small bowel, even if they have hyperbilirubinemia, as long as they have a normal INR. Patients with advanced liver disease, but a surgically repairable small bowel anatomy. And again, there can be a number of procedures that one can entertain. And the experienced intestinal rehab programs are remarkably successful. This one study, which was done 20 years ago, a 96% survival in this category of patients, with 60% off of parenteral nutrition, 23% on partial TPN, and only 12% ultimately going to intestinal transplantation. So, how do we manage these patients? Well, again, it's better to have them at home than in the hospital. Most intestinal rehab programs will try to manage these patients at home because the 1-year survival in home TPN patients, 74% compared to 59% in the hospital. Refer early to avoid combined liver and intestinal transplantation. Consult the patient in the NICU and immediately post-surgery to help predict what the clinical course may be depending upon all of the factors we've discussed. The overall survival of patients in intestinal transplant programs is about 70%. 90% 3-year survival in patients who have an intestinal transplant. 2/3 of patients, again, in total, who are managed in intestinal rehab programs will be weaned from parenteral nutrition. However, only about half of them will achieve a totally normal growth based on genetic predictors. So it's not 100% successful, but the patients survive, hopefully, with a limit in their limitations. The indications for intestinal transplant, again, prolonged hyperbilirubinemia or problems with stomal bleeding, cirrhosis, thrombosis of major venous access. Again, this is a major problem in patients on long-term parenteral nutrition. Problems with recurrent catheter-related sepsis, underlying disease causing high water and electrolyte losses, and unacceptable quality of life. With the development of teduglutide, certainly this has been limited, and with the development of our knowledge of how to prevent TPN-associated liver disease, the problems of liver disease leading to transplantation has been reduced significantly. Contraindications for transplantations, poor recipient condition, the presence of congenital or acquired neurologic impairment, life-threatening diseases outside of the GI tract, congenital or acquired immune disorders. Obviously, these patients have to be immunosuppressed, a non-resectable malignancy, or insufficient vascular patency to guarantee access for 6 months post-intestinal transplant. This is extremely important because patients on long-term parenteral nutrition have indwelling catheters. And when you start to see the sites being used up, that can become a significant problem in terms of survival. What about intestinal isolated liver transplantation in small bowel? The liver disease obviously interferes with gut adaptation. Liver failure can lead to early death. And if we look at 11 infants with 25 to 100 centimeters beyond the ligament of Treitz, 8 survived up to 66-month follow-up. Only 2 were still on partial parenteral nutrition. So the advantages of isolated liver transplantation is that there's greater organ availability, there's lower immunosuppression, so it's better tolerated, and there's greater experience and success, even with small infants. However, with the techniques that we've learned to try to limit liver disease, liver transplantation in intestinal failure should be reduced dramatically over the next several years. In terms of, again, isolated liver transplantation, you want to predict enteral autonomy after isolated liver transplant, and these patients should be able to tolerate more than 50% of their calories initially via the enteral route. They should have a stable stool output, hydration, and growth, and they should have small intestinal length that's greater than 25 centimeters from the ligament of Treitz. The younger the patient, the better the prognosis, again, because of the prognosis for gut growth. So the essentials of managing intestinal failure, liver disease: feed even in tiny amounts, hook up the colon, cherish the line, resist line entry, engage in meticulous line care, avoid parenteral overfeeding, if possible, cycle parenteral nutrition and give bolus feeds, allow some oral feeds, prompt intervention for anything that might even suggest a bacterial infection, anticipate and monitor for complications, early consultation to intestinal rehab program. Don't be a hero. If you have a patient whose length of small bowel or site of resection predicts a long-term course on parenteral nutrition, these patients should be referred to an intestinal rehab program. And then early referral for potential small bowel transplantation. That really is something that we really don't have to engage in. We really need to engage in the early consultation to an intestinal rehab program. And that's it.
Thank you.
Thank you, Dr. Schwarz.
You're welcome.
Thanks, Steve.
All right.
Thank you.
Thank you. These patients are clearly very complicated.